Since last year, a severe respiratory epidemic has been sweeping through the population, overwhelming hospitals with patients. At the hospital where Dr. A works, all 9 ventilators are already in use. And only one ventilator remains available. Then an urgent call comes in. 2 patients need ventilator support. One is an 82-year-old former member of the National Assembly. The other is a 32-year-old man, an office worker and the father of a 2-year-old daughter. Who should receive the ventilator?
During the COVID-19 pandemic, similar situations occurred around the world. Hospitals were overwhelmed, intensive care units were full, and ventilators became a scarce and life-saving resource. In some countries, morgues overflowed so much that bodies were stored in refrigerated trucks. And even military vehicles were mobilized to manage the crisis. One of the most controversial issues during the pandemic was exactly this. Who gets the ventilator when there aren't enough for everyone? Ventilators can save many lives, but they require not only the machine itself, but also ICU space, medical staff, and high costs to operate. Under normal conditions, hospitals maintain just enough ventilators. But when a respiratory epidemic surges, demand suddenly exceeds supply. And doctors must decide who gets treated and who doesn't. Typically, hospitals give ventilators to the patient who arrives first. But when multiple critical patients arrive at the same time, doctors decide who has priority for ventilator. Many countries developed guidelines, but these sparked heated debates. For example, the British Medical Association recommended prioritizing younger, healthier patients over elderly patients, patients without underlying health conditions over those with chronic illnesses, and essential workers in critical sectors such as healthcare and infrastructure. These guidelines raised difficult ethical questions about what criteria should be used to allocate scarce medical resources. If the goal is to maximize total lifespan, it might seem logical to save one young person rather than 2 elderly patients. If the goal is to maximize the number of lives saved, then saving 2 elderly patients may take priority over one younger person. Doctors also can face cases where a patient with a lower chance of survival and one with a higher chance need a ventilator at the same time. In that case, doctors also have to decide who deserve to use the ventilator. Furthermore, what if a ventilator is already being used by someone with little chance of survival? Should it be reallocated to someone else who might survive? This dilemma isn't new. In the 1960s, when dialysis machines were first invented, there were far fewer machines than patients with kidney failure. In Seattle, a committee of citizens and medical professionals was formed to decide who would use dialysis machines. Doctors leaned toward medical criteria, using dialysis machines to those with the best chance of survival. But the committee also considered social value for use of dialysis machine priority. This concept of social value meant prioritizing individuals who were considered responsible, upstanding citizens, including people with no criminal record, stable family backgrounds, a record of public service, or career success. In practice, this often favored older, socially established individuals over younger or medically more suitable patients. Now, imagine we're back to the ventilator shortage. What criteria should we use? If we prioritize medical urgency, we may end up wasting the ventilator on someone who cannot be saved, leaving others without a chance. If we prioritize those most likely to survive, we may be accused of playing God, and severely ill patients might die without ever receiving treatment. If we prioritize maximizing total life years, elderly patients who have contributed greatly to society might be denied access to advanced care. This can feel like society abandoning its seniors, contradicting the ethics we were taught to protect the vulnerable, like the elderly and children. If we prioritize social value, ventilators may go to the rich, powerful, or famous, which leads to accusations of social and economic discrimination. There is no perfect answer. Every choice carries moral weight. But in a crisis where not everyone can be saved, decisions must be made. Who should be prioritized when ventilators are limited? Should it be the young, the sickest, the most likely to survive, or those with the greatest social contribution? Share your thoughts and opinions in the comments.